This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Have a tremendous opportunity just in mainstream medicine to do a lot better, than we do with the communication piece. And so that is my soapbox. My pharmacy team that I work with, student pharmacists that come through my rotation, the words that we use matter.
This is the Heart of Hospice podcast with Helen Bauer. I'm talking with hospice pharmacist Ellen Fulp today about how medications are used in end-of-life care to manage symptoms and keep patients comfortable. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice podcast is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
This episode is sponsored by Odonata Care, creators of the Hospice Care Plan. Hospice agencies and end-of-life doulas are now using the Hospice Care Plan booklet to support their patients and caregivers. It's become a trusted resource in the end-of-life community, helping to educate and equip caregivers. Visit thehospicecareplan.com today to purchase the Hospice Care Plan booklet. The sponsor for this week's episode is Barbara Carnes Books, featuring the work of award-winning hospice RN educator Barbara Carnes. BK Books is proud to offer the End-of-Life Guidelines series, a compilation of 5 essential education booklets designed to support those caring for terminally ill loved ones. Visit bkbooks.com today to order the End-of-Life Guidelines series to support your journey of compassionate caregiving.
My guest today is Ellen Fulp. Ellen is a PharmD. She enjoys spending her professional time collaborating with patients, families, and clinicians to maximize the benefits and reduce the risks surrounding medication use. Ellen is board certified in geriatric pharmacy, so she specializes in safe, appropriate med use in the elderly. Ellen also works closely with state and hospice and palliative care organizations to improve quality of life and medication use for patients that are facing serious illness. She's dedicated to improving pain management in the geriatric patient population and expanding access to palliative care resources. Ellen and I had a great conversation that I think is really important. I've never had a podcast featuring a pharmacist before. So a pharmacist that collaborates with hospice teams, it's right up our alley, and it's some great information. In our conversation, Ellen talks about some of the misunderstandings about medications and how they're used in hospice. As a pharmacist, she goes to great lengths to make sure she understands the patient and the caregiver's fears and needs about their medications. She also talks about the safety measures that pharmacists will employ when it comes to having medications out in the home of a person who's on hospice. She's going to be explaining the process of deprescribing medications for hospice patients, which means basically unprescribing, taking off medications, and how to reduce pill burden, which is that great number of pills that so many patients that are close to end of life end up with. Ellen's purpose for working in hospice is to help relieve people suffering with the use of medication. She's very knowledgeable and very adept at these conversations. So sit back and relax. Here's my discussion with pharmacist Ellen Fulp. Ellen, welcome to the Heart of Hospice podcast. I'm so glad to have you on the show.
Thanks. It's a pleasure to be here, Helen. I'm so excited to have this discussion with you today.
And it's such an important discussion. I'm a little bit intimidated. I've never had a pharmacist on this show before. So we're going to be talking about actually some very, very important topics that are probably some of the most misunderstood areas of end-of-life care.
Yes. And it's a privilege to be the first pharmacist with you. And we do have a unique role to play assisting with medication appropriateness. And as you say, medications are often kind of misunderstood. And there's a big role to help the public and the patients and their caregivers for really anyone with a serious illness. So thank you. Yes, it's a true honor to be with you.
Well, thank you. Well, we're going to start off with an icebreaker question. And I'm a little death deck obsessed. So your question is coming from the death deck today.
All right.
Given a chance to choose your very last meal, what would you indulge in?
Oh, gosh, that's a good one and a tough question. So probably something that is a family recipe. So I'm from North Carolina, rural part of our state, and sharing a meal is such a social, experience with friends and family. So I think I would love to share my last meal with a loved one. And I think it would be some form of potato. I think maybe like a good, homemade scallop potato with a loved one. That would be my last meal.
I like it. So carbs is what you're telling me.
Yes.
You're going to go for the carbs.
Carb heavy, right.
Mm-hmm. That's probably why it would be your last meal.
Right. If I made a trend, you can see a trend there. Right. You got it.
I like that. Okay. So pharmacists inside hospice, who knew that was even part of the team? So really, pharmacists play an important role. It's behind the scenes, but they do a lot of coordinating when it comes to managing patient medications. So when it comes to the role of the pharmacist, what is the role of the pharmacist in the care of a person who is on hospice?
So that's a great question. And when you say who knew, the brutally honest answer is not me. When I started working in hospice, I really didn't know how dynamic a role it could be and exactly how impactful it could be for a patient's quality of life. So you are correct. We are not what CMS or the Center for Medicaid, Medicare Services would define as a core, hospice team member. So we're not, required, if you will, much like the hospice physician or a nurse or a chaplain or a social worker. But we absolutely support that care team in determining the appropriateness of medications that are on the hospice drug profile. So I would say our biggest role is pretty obvious, right? We're going to be the medication experts. And I think that's really important because as patients are progressing through an illness trajectory, the likelihood that they will have symptoms that cannot be managed without drug therapy, that likelihood is just kind of ever increasing. And so our patients don't just experience pain in a silo, nausea, vomiting in a silo. They have a lot of kind of active problems very frequently. And so the likelihood that they are experiencing polypharmacy or prescribing cascade is actually, increasing over time as well. So the pharmacist can really be a nice tool in making sure that patients are on the medications that are really offering the biggest bang for your buck, if you will. So they're helping with symptom management, and we're also trying to limit adverse effects at the same time. And these are also patients who very frequently will have end organ damage or complications that make the use of even a single medication a lot more complicated. So we're helping just clinically, which then often translates to increased quality of life. And then the part that I really didn't know going into this role in hospice specifically is the regulatory component of just making sure that everything that we're doing is appropriate clinically for our patient, but is also the best regulatory, kind of best practices for the hospice agency. So we're always consulted by wonderful hospice clinicians, but the ultimate goal, of course, is patient comfort. And with all those moving parts, it really does help to have that drug expert, as the extension of your hospice team.
Absolutely. And I can kind of testify to that as a hospice nurse because I know the regulatory part, right? We have to have it reviewed. It has to be by somebody qualified, and nobody is more qualified than your pharmacist to look at the big picture, the umbrella of all the medicines that are being administered. So for my listeners who are caregivers, who are lay people, we're going to make sure that we have content that with words that everybody understands, right? Because we get deep in the weeds when it comes to medications for symptom management. So when we say polypharmacy, what we're talking about is multiple medications.
Right. I think to your point, exactly as you're describing, we start a medication, we have the best intent, right? There's an active symptom, right, that's causing problems for the patient. We treat it with one medication, and instead of recognizing something as a side effect that this medication causes makes you feel poorly, we'll add another medication. And so now you're on 2 medications, right? So we start treating the side effect instead of the person or their new symptoms. So yes, it happens all the time.
Well, and a lot of our older patients come to us with that already going on, and they call it pill burden because for that patient to have to put all those pills in, the caregiver to have to administer them, and sometimes not administering them in that whole form, but having to dissolve them in something else or having to crush them, get them into to a food that a patient can manage. All of that gets to be a big burden on the caregiver and the patient. So those are also things that the nurse and the doctor and the pharmacist are coordinating. Like if we want pain management, but we need it in a different form, the patient's beginning to change and can't swallow, the mentation's different, the patient's more sedated than the family would like. All of those considerations are things that the clinical team, the nurse and the doctor, along with the pharmacist, are coordinating. So there really is a lot going on behind the scenes that the family and the patient may never even know about when it comes to coordinating on meds. So one of the biggest misconceptions about hospice care, I guess several of the biggest misconceptions about hospice, has to do with the medicines. The biggest one, I think, is probably that the team's going to take away all your medicines as soon as you get admitted, which for my listeners, that's not true. The other thing is the patient and the caregiver won't have a say in what medications are utilized. That's also not true. Morphine is always used. That is not true. That is absolutely not true, and we're going to dive deeper into that. Also, another misconception is that patients are sedated until they die. That is a myth. That is not true. So let's talk about the truth of the matter. How are medications really utilized when someone is on hospice care?
Right. So I agree with you completely, Helen. A lot of the myths that surround hospice care involve medications, and it's always surprising to me, or at least initially when I started working in hospice, was surprising to me that patients were very familiar with opioid analgesics or, morphine, for example, other drugs that are in that class. And there was a huge fear factor there when medications can alleviate pain, they can alleviate suffering, and when used appropriately, they might not cause sedation. It's patient specific. So if I had to sum it up, in a sentence, I always tell patients and caregivers, they are the experts at being themselves. So if there's something that they are really concerned about on the medication profile, I want to talk about it first before I make a single recommendation. So I like to ask questions of, my patients and their family members. Tell me what I need to know about your medication list. It's an open-ended question, and they are free to share with me that they're fearful that the team might prescribe morphine, or they're really afraid about stopping a medication for cholesterol or blood pressure that they've been on for years and years. And so that allows me to create a safe space and follow up with, well, why is that something, that scares you? Or could we talk a little bit more? And then I'll share a little bit, because a lot of these medications that patients have been on for years and years, they are realizing the benefit of taking that drug, over a 5 or 10 year period. And very often there's not a harm in stopping the medication for several weeks and doing a trial, and then we'll see if the patient feels any differently. And the beautiful thing about hospice is we're going to be there with the patient and the family member to continually evaluating what's right today in their care. So it's not to say that the medication that they understood from their specialist or their primary care, physician is never going to be reasonable and necessary to continue. It might be. So let's talk about it. And then the beauty of that, relationship, once we've built it together and we've explored the hospice drug profile or just the patient's medication list, we can talk about how well it matches their quality of life today. So you mentioned pill burden. When patients are, nearing the end of an illness, they might have 20 medications or more. And there's a tremendous pill burden. It might take half an hour to take all of those medications. And then the patient has consumed so much water. Now they're full and they can't eat the foods that they enjoy. So there's definitely a lot of that. And I know you've seen it too in your hospice career. And so if you have, a hospice team that's willing to just talk about it, right? What medications scare you? How can we make that better? And we talk about all of the safeguards that we put in place. I find that really is the best way forward, because our ultimate goal in hospice is to relieve suffering and increase quality of life. And very frequently, the benefit you're getting from your medications is different than it was 10 years ago, 15 years ago. The goal is different. So I think just being open and transparent with patients is really helpful in making sure that the meds that we have in place really match the patient where they are.
Oh, I think that's a really good point. The meds should match the patients where they are. Mm-hmm. So would you say that probably the medicine that more people have a problem with or concern about is the morphine?
I think so. Morphine or other pain medications, we use the drug methadone, which is a relative of morphine in the same drug class, quite a bit, because as you said earlier, what a patient needs today might be different, meaning maybe a patient can't swallow today, but they have a need for a long-acting or an around-the-clock type of pain medication, maybe for cancer or something that's really painful. A switch to something like methadone that has a bad reputation sometimes is the best option for patient comfort. But to me, it's not the best option unless the patient is comfortable trying it. And if we, until we have a safe plan or means to use the medication in the patient's home, wherever that is. But I would say the number one most feared medication, or the one that I hear about the most, is a hesitancy to use morphine in the home. Yeah. Absolutely. And I think that it's different for every patient why they fear the drug. Most frequently I hear folks say that they assume that's only used in the final days of life, or that it causes sedation, or that's why the patient's, care team is using morphine as for sedation. And we never use morphine for sedation in hospice. It's for the relief of pain or shortness of breath. And we actually find patients who rest more comfortably because they're not in pain. But quite often that results in a patient who's a lot more interactive with their family members. They're not having anxiety because they are having pain. They're actually getting good rest when rest is appropriate. And then they're a lot more interactive because we're controlling their pain or their hunger very well.
Well, there's such a lack of education. And then I think there's a stigma around morphine. People that are unfamiliar with it, how it's used, and how we use it. I hear stories of people that say, 15, 20, 30 years ago, grandma was given morphine while she was on hospice and it made her die. What it did was get her comfortable enough to do the work of dying. Mm-hmm. But this is the association that's made, and it's really hard to change people's minds. And there are other reasons that people don't want opioids, not just morphine specifically, but other opioids. If there's a diversion issue in the house, if there's someone with a substance use disorder, diversion is simply the act of somebody else taking the medicine that's not supposed to have it, somebody other than the patient. And I know a lot of families struggle with that. They get concerned that there will be a relapse. I remember having a patient, he had had a head and neck surgery for, I think, oral cancer or cancer in his jaw. And he had been given an opioid, but he was a recovering alcoholic and a recovering drug addict. And it broke his sobriety that he'd had for years. And he had made it very clear that he did not want to take anything, that he did not need it at that point, right? He wasn't in terrible pain, but he had been given something inadvertently that he did not realize had alcohol in it, had an alcohol base. This was years ago, but he was upset because it broke his sobriety.
Right. And I think you bring up, an excellent point, several, as always, Helen. So the first, we are living, in what the CDC, the Center for Disease Control and Prevention, what they would call an opioid epidemic. So a lot more, lay people or just the general public, they've heard about opioids, right? Even if they haven't been personally prescribed one. And I think it's appropriate to view any, controlled substance, a drug that has potential for harm, to kind of view that reverently, if you will. We need to take additional safeguards. We need to make sure that we're selecting the right patient for the right product, especially in that case. I think the other, certainly a challenge for patients living with the disease of addiction, we definitely want to make sure that they have the right to weigh in on their therapy, of course, just like anyone else, but we might have to make, a more judicious selection of a medication to ensure their safety and their comfort. But one of the things that I think is a beautiful movement that I've seen, in hospice care is to screen for the potential for inappropriate substance use or taking a medication in a way that it was not prescribed for both patients and their family members. So even if the patient hasn't been formally diagnosed with some form of substance use disorder, we can use a set of, kind of questions, a screening tool, just to make sure that controlled substances can be used safely in the home. And sometimes that does trigger a nice discussion to make sure that the patient is fully informed about, expectations for safe medication use. That's another kind of role of a pharmacist, I think, in the hospice and palliative care supportive care space, is to make sure that the therapy that is recommended can safely be used in the home when it comes to drug therapy, because so much of hospice care happens wherever the patient calls home. So it's not like you're in a long-term care facility or a nursing home or a hospital. That's the beauty of this model of care. We can get the therapy to you wherever you call home. And so I think that might, in some patient cases, involve, a secure lockbox for a medication. We can certainly prescribe smaller quantities, use, single pharmacies, and just really do some great follow-up with patients and their family members to make sure that symptoms are controlled, but also that the patient is safe. The medication supply is safe and not a harm to loved ones or pets or the community. So there's a lot of education, a lot of patient weigh-in, and then a lot of kind of behind the scenes, as you say, work for the hospice to make sure that all of the medications can be safely used wherever that patient is calling home.
Yeah, because the home situations differ from patient to patient, right? We walk into homes that are unsafe. Maybe there's a lot of family foot traffic through, and that screening tool, I think, to ask to assess what the risk of diversion is a really important tool, because we are responsible for the medicines that we're putting out there. And if a lockbox is what's needed, I think it's important for patients and caregivers to know that they don't have to automatically say, well, no, we can't ever have that in our home. There are things that we can do to take steps, a lockbox in there, doing what you're describing, giving smaller amounts. We call it a short fill. Instead of filling you every week or every 2 weeks, we can do it for just a few days at a time. And if that's what's necessary, we can. And there are ways of prescribing meds for symptom management with medications that aren't things that people seek after. They don't give you the buzz, they don't give you the high, and so it's not something that's typically abused or diverted. So there are choices we can make. So that screening tool, once we find out there's a concern in the home, Sometimes it's not the caregiver. Sometimes it's not the patient. Sometimes it may just be a family member that's in and out. But that family wants to make sure that there's not going to be an issue.
Right. And I think that's also what gives a lot of patients or their family members or caregivers just a lot of peace surrounding using medications for pain or anxiety. It's always our goal with pain specifically to be as morphine sparing as possible. So if somebody has a chronically painful condition, we always use a chronic cancer type pain as our example there. Even in hospice, in palliative care, we know the likelihood that the patient might progress to needing a scheduled morphine or morphine-like product. The likelihood there is pretty high if somebody is in the terminal phase of their illness, but we still are going to use what we call adjuvant analgesics. And those would be drugs that are morphine sparing. So things that might help with inflammatory type pain or nerve type pain. And we found over time that if we have those doses of alternate medications prescribed appropriately, we might use a little bit less morphine, or patients might need morphine, at lower doses. And that definitely, I think, has put a lot of minds at ease in the work that I do, just making sure that folks know we're using morphine or morphine-like products only when it's absolutely necessary, only in a manner that's safe, that's agreed upon by the hospice agency and the patient and their loved ones. Because that's an excellent point that you make again, Helen, that the hospice or the prescribing agency is ultimately responsible for making sure that the drugs that are prescribed are done so, it's appropriate process. They can be used safely. There's a plan in place for disposing the medications, if needed. Really, it's a process that the patient and their caregivers really have the word of the hospice that the agency will be there to help make sure that the drugs are safely used and disposed of.
Yeah, that's just part of our job. So using the adjuvant medications, which it's basically a buddy system of medications that support and supplement the opioids, things like steroids, things that people are much more familiar with, right? Steroids and ibuprofen style drugs, NSAIDs, things like that, that add in. And so we're sparing the need for all the morphine, for the heavier drugs. And I think patients and caregivers knowing that, those are more familiar drugs, a lot of them over the counter. It's very familiar, and it's a little reassuring that we don't have to use so much of the opioid that people have so much concern about these days.
Mm-hmm. And I found that honestly to be kind of a double-edged sword. Sometimes people are more familiar with things like NSAIDs, ibuprofen, naproxen, because you can find that on the over-the-counter, aisle at your local drugstore or pharmacy. Things like Tylenol, similar situation. When we use those at appropriate doses and, usually scheduled throughout the day, they can be very impactful for many types of pain. So some caregivers or patients will hear those types of drugs, Tylenol, ibuprofen, naproxen, and they think they're not strong, or they're not appropriate because they've tried them before. So that's also a great, I think, piece of advice, just to be curious with the patients that you're serving and with the care teams that are supporting you, to just be very transparent about how you've used those products before, because it could be something as simple as scheduling the Tylenol tablet 3 times a day and taking it on a very kind of routine nature that's going to help it, kind of attack the pain appropriately. So yes, it could be a combination of products that we use if that's appropriate for that patient's pain, or in some cases we will deprescribe or just gradually taper one product and use a single agent, but just use it on a scheduled basis. So all of that is based on the patient and the caregiver and their input on what that pain experience, or whatever the symptom is, what that experience has been like for the patient.
Yeah, it's quite a science and an art to be able to balance this symptom management in a way that promotes quality of life and still manages the symptoms, because we're also looking at quality of life for the caregiver in a way, because caregiver burden, and when it comes to giving medications, the time consumption and the effort, it can be a huge a huge issue when it comes to caregiving. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
As hospice professionals, you understand the vital role that family caregivers play in ensuring quality end-of-life care. However, caregivers often feel unprepared and overwhelmed when the hospice staff isn't present. The Hospice Care Plan, A Path to Comfort, bridges this gap, equipping families with the knowledge and skills to provide exceptional care at home. Listen to hospice nurses Nancy Hireman and Brenda Kazire share why they created the Hospice Care Plan.
As nurses know, when you're out there providing care, you want to provide the best instruction to the entire the entire care circle. That would be the family, the hired caregivers, friends, neighbors, of course, the patient. And there is never enough time to teach what is really important. You certainly can't write down all the instructions when you're in the home. And so we realized we need a tool that can follow us out of the house, basically.
Yeah.
When families feel equipped to handle caregiving responsibilities, they can focus on cherishing time with their loved one. Implementing the Hospice Care Plan as part of your hospice program ensures that your families have the tools to provide the necessary care between visits from your staff, increasing patient and caregiver satisfaction. Invest in this powerful resource to support your mission of providing quality end-of-life care. Visit thehospicecareplan.com for more information. Want to learn more about caring for someone at end of life? Discover the End of Life Guidelines series by Barbara Carnes. Here's Barbara Carnes to tell you more.
There is a normal, natural way of dying. My materials are written to guide and support anyone who is addressing end-of-life situations. The goal is to help people have a positive experience so families will have a sacred memory to carry with them.
The End of Life Guidelines series prepares readers for the natural, normal process of dying and grief. It's a compilation of 5 of our most popular books, including A Time to Live, Living with a Life-Threatening Illness, The 11th Hour, A Caring Guideline for the Hours to Minutes Before Death, Pain and End of Life, What You Need to Know About End-of-Life Comfort and Pain Management, My Friend, I Care, The Grief Experience, and the most widely used hospice book, Gone From My Sight. To order the End of Life Guidelines series, visit bkbooks.com. This series is available in digital format and volume discounts are also available. Just visit bkbooks.com.
So I want to talk about some of the more challenging symptoms that we deal with and how pharmacists collaborate. So some of the things that we deal with, like terminal agitation, which in my experience has always been a fairly challenging symptom to manage when it comes to during the dying process. Delirium is another one. So pharmacists are very, very collaborative and very helpful when it comes to managing those symptoms. So tell me how the pharmacist works with the nurse and the physician when it comes to managing a symptom that's gotten out of control, like agitation or delirium.
Yes. So in an ideal world, I think that
I like the way this sounds.
Yeah. So I'll tell you my ideal, and then I'll tell you kind of how things happen today. So I think in an ideal scenario, we would focus on medication appropriateness, really making sure that the meds that we have on a patient's drug profile, that they are appropriate, meaning the benefit is continuing to outweigh the risk, that we would have those check-ins a lot more readily, even years upstream from somebody receiving, a hospice referral or serious diagnosis.
Oh, I see what you're saying. You're saying having a pharmacist involved in a patient's care way before hospice.
I think so. And I think that's really what pulled me to be more interested in supportive care for somebody with a serious illness. So palliative care and not just hospice for someone who's living with, kind of a life limiting illness at this point. Right. Because, when I'm in a palliative care kind of setting or get a palliative care referral, so upstream from hospice, I've worked recently with a Parkinson's patient, and they were educated in that initial diagnosis conversation, the neurologist said, but don't worry, this won't be what kills you, to this patient who was, 75 years old, lived, with his elderly wife. And I thought we probably could have chosen different words to say that, because this is still going to be a very burdensome road for both the patient and his elderly wife. And so, in his mind, he's thinking this new debilitating, condition is not that big of a deal. And I even think about diabetes in the same way. I think it's great that we teach people how to live, with their disease, but it's going to complicate and compound about anything else, that happens to that patient from a medical standpoint. So really just normalizing that things change, that a medication list is not this stagnant thing that's as unique to you as your fingerprint. Like it's always going to be there. It's going to be this way. I think just normalizing that things will be different and we need to change things and be more fluid with the process, that I think would be the ideal involvement. Just kind of treating a serious illness as a serious illness kind of further upstream. But I do think it's an extremely important time in a patient's life. We only, die one time. So our care team gets one chance to make sure that the patient is as comfortable as possible, that the family members have all of their concerns alleviated while someone is, kind of going through the dying process, or we anticipate that that is, very near for the patient. And so, yes, things like what we call terminal agitation or delirium tend to be very common in the dying process for certain subsets of patients, but we know that it's commonly experienced. And so the beautiful thing about, the hospice pharmacist kind of model, most hospice care teams have a pharmacist on staff or in a supportive role for their agency. And so we basically I like to think of it as a phone a friend. So phone a colleague, and we talk about what the patient is experiencing, how they're able to take medications. Can they swallow? Can they passively kind of swallow something? Maybe they have an IV, in place. And we will do very often what I like to call a time limited trial. So we might say for the next, 12 hours, we want to use this medication every 2 hours as needed. Call me back. We'll make an adjustment. So we do a lot of symptom severity. So if it's agitation, the wonderful bedside clinicians will kind of rate the severity, if it's getting better, if it's getting worse, and, kind of what we think might be a good option next. And then we come right back to the line and reassess that symptom. And this is really important because a lot of the medications that we use, just like anywhere, in modern medicine, will have a side effect profile. They might not be the right agent for that person. And so I love the hospice, kind of model, because we meet with our care teams every 2 weeks, for a patient that's a little bit more stable. So you get this whole robust team that's reviewing your care, all of your medications, and we'll make changes if needed. And the same principle applies in this scenario. So if someone is, experiencing terminal agitation in the final, hours to short days of life, the same philosophy holds true, but we're just meeting as frequently as needed, virtually, in person. Again, it just kind of depends on where you are and where your care team is, but definitely get a lot of calls in those scenarios because as we talked about, we're kind of kicking things off, Ellen, the pharmacist tends to be a lot more involved when there's an active symptom that involves medication management. And very often that's what's happening in this scenario.
Right. And it can get fairly complicated. We know that. I have been on the phone with pharmacists and had them compounding, a Valium suppository if they weren't readily available and picking it up at 2:00 in the morning. There's a lot that goes into it. I love the thought of the upstream involvement of a pharmacist. And so I want to go back. We take the administration or the prescribing of medications very casually. We see this every day, right? Clinicians that order it, clinicians who deliver it, clinicians who teach about it. This is our normal every day. It's not normal for these patients and these caregivers. They have a lot going on. They're grieving, tired, maybe financially strapped, overwhelmed. There's a lot that goes into it. And then we have a tendency to say, oh, you don't need to worry about this. We do this all the time. But they don't. I don't think it's ever a good idea to devalue or degrade someone else's concern, as evidenced by the doctor that told the patient. That was really his way of saying, I'm trying to show you that you don't need to be scared about this. I don't want you to be scared about it. But what it came out as was, oh, this isn't going to be what kills you.
Mm-hmm. Yeah, I think ultimately, or I like to think, right, that neurologist was trying to share with the patient, this is a disease you can live with.
Right.
We've got options, like treatments are a lot better than they were.
Right.
Because
it's not a death sentence.
Yeah, exactly. Yeah. But I think the part that was completely overlooked was how serious it was, or what that life was going to look like, and how that was different, and what supports were available. And so, yes, I think that we have a tremendous opportunity just in mainstream medicine to do a lot better, than we do with the communication piece. And so that is my soapbox. My pharmacy team that I work with, student pharmacists that come through my rotation, the words that we use matter. And the patient is always the expert at being the patient. And so we have to ask, we have to be curious, or we'll never have a good pairing of the medicine or the therapies that match the patient and where they are now. And I think that's something that's been instilled with me always. So back working a community pharmacy counter, 15 years ago, it was a privilege, to educate patients on their medications, but it might have been, they'd seen their physician, they'd seen, a specialist, they'd picked up their medication 2 or 3 times, and then they realized that they still had questions. They weren't well informed. And, I can remember checking for, lower extremity edema for my patients in the waiting area, and just answering, all of their questions. And they, you could see light bulbs going off. And so, I think that there's a lot that can be done to make sure that patients can make the best decision for themselves. We don't always give them all of the pieces of the puzzle, because it's such a comfortable, experience for us as hospice clinicians. We have seen these symptoms, thousands of times, but it's the patient's first experience. And I think letting them have that space to be curious, and us providing information in a manner that's really supportive of shared decision making, because we do need to be, the clinical expert, right? If I'm giving you advice as your pharmacist, you want me to give you all of the pieces, right, about this medication, this drug therapy regimen, so that you can make a good informed decision. But I still need to hear your questions, your concerns, and how a medication needs to, be administered. Or, to your point, is it something that I can give on my schedule that's convenient enough so that I won't miss a dose? Things like that.
Right.
We've got to ask those questions, and we've got to share information in a way that the patients and family members can digest it.
Well, realistically, if we're supposed to be providing individualized, personalized care, how can we do that if we don't even know these people? Until we get to know them, what's important to you? What's his quality of life? What kind of activity level do you need? Do you want? Are you capable of? Until we ask those questions and listen to what they're having to say, we can't really create any sort of plan of care that's individualized, because it's just not about them. It's more about what's convenient for us.
Agree.
Yeah. Okay, so pharmacists can work in so many different silos. Retail pharmacy, hospital pharmacies, all sorts of things. And you have chosen to work with a company that works with people who are dying, terminally ill patients, people at end of life. Why? Why end of life care for you?
So I think initially. When I graduated pharmacy school, I don't think I could have really explained to you what hospice was, or, what any kind of palliative care was. It wasn't something that was, kind of sold to us as the latest, greatest niche in pharmacy, like cardiology or pediatrics or emergency medicine. But I'll tell you, geriatrics, I'm board certified in geriatrics. And so I've always been called to geriatric, pharmacy, because I think we can do some of the greatest good with medications, but we also can do some of the worst harm with medications. Just because of how our bodies are designed and they change over time, our drug therapy needs to change over time. And so when I actually took this position in hospice and palliative care, I got really passionate about making sure that we used medications appropriately for patients who were at their most vulnerable. You've got a lot going on, like you said, in a hospice admission visit. There's so much information just in that one visit, for example. To me, the human body kind of feels like that, or seems like that, while you're on hospice. There's just so much that's changing. And so you need a care team that includes a pharmacist who can help you use medications when you really need them the most, but you also need a clinician who's really passionate about having hard conversations and decreasing the harm of those medications. And so when I went back and started pursuing additional education in hospice and palliative care, a very similar question was asked, and it was pretty eye-opening in this experiment. So our oath of a pharmacist, the very first thing that we say as a new graduating pharmacist, and part of our oath, I will consider the welfare of humanity and the relief of suffering my primary concerns. And so I can't think of an area, of pharmacy, of medicine, where I have the ability to do that, any more effectively than in hospice. So just making sure that the relief of suffering and just that quality of life, however long that might be, for a patient, that I'm part of that, ensuring that their quality of life and their, kind of reduction in suffering is my primary concern when it comes to using medications.
Yeah, that oath is at the heart, very heart of what we do in end-of-life care. So, Ellen, if you could have a one-on-one conversation with a hospice patient or a caregiver right now, that we're having to make these decisions and looking at administering these meds, what would you want them to know about how hospice helps with medications?
So I think even that would be a fairly individualized, conversation. I always start with, what's the number one thing that I should know about you, just as a patient, not, when it comes to the medication list. But I think ultimately the information that I would really want to impart is that this will be a medication list that you absolutely weigh in on, and that our goal is to have the patient symptoms, whatever they just, describe to me or to their care team, that we're doing the very best that we can for symptom resolution, keeping their goals of care in mind. So if it's to be as awake and, interactive as possible, that they have our commitment as the care team, that we will bring medication options and kind of share what the trade-off for symptom management would look like. So I think my ultimate objective would be to distill any fears that they have about whether it be morphine or anything else, whether it be about deprescribing, so tapering or discontinuing a medication, and just really how involved the care team will be, so that if they stop a medication, if they start a medication and they have a side effect or an adverse effect, that this is a care team that means that when we say we'll be right there, to have a follow-up conversation. So for me, the primary objectives would be to kind of help address any fears that are present, and to share that the care team will be present and help them make the best medication decisions possible.
I love it. It gets to be all about them.
Yes, yeah. That's why I love it so much. Yes.
That's wonderful. Ellen, thank you so much. My first pancake, my first interview with a pharmacist. It's been great to have you on the show. Thank you so much for sharing your wisdom.
Yes, the pleasure's all mine. I hope I was a good first pharmacist. It's certainly our pleasure, I think, overall as a profession to be part of this wonderful work that the hospice teams do. So thank you so much for this opportunity. It's been great. Thanks, Helen.
Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com, and don't forget to follow us on your favorite podcast platform. You can connect with the Heart of Hospice on Facebook and Instagram, and send your questions or comments by email to helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.